The coronavirus pandemic has been the top medical issue of 2020. So why don't antibiotics work to treat viruses, and what can be done to treat them instead? We'll talk with HSHS St. Anthony's Chief Medical Officer, Dr Jennings, about that coming up next on Being Well.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.
They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. The ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
Thank you so much for joining us today for Being Well. I'm your host, Lacey Spence, and today we are joined by Dr. Jennings. Now, you were telling me that you've got a fabulous new title. Can you run us through that?
Oh, yeah. I've expanded my role since the last time you saw me. I've normally been the Chief Medical Officer at HSHS St. Anthony's, but now I'm also covering HSHS Holy Family in Greenville, HSHS Good Shepherd in Shelbyville, as well as St. Mary's in Decatur. So more work. Reward of a job well done, I guess.
Sure. So what does it mean to be a CMO? What does that entail?
You know, my primary focus is around quality and trying to help the hospital to kind of understand the perspective of the physician and what the physician role in quality is, and at the same time help the doctors kind of understand how the hospital works. So it's kind of a combination between the boardroom and Wall Street Journal versus the New England Journal of Medicine, somewhere in there. I stole that quote from somebody, I don't know.
Well, we're certainly glad to have you back on the show. And so today we are kind of talking about antibiotics, their roles. And so from a hospital perspective, how can antibiotics, I guess, kind of not be great, not what they're used for?
Well, you know, it is a fine line, and we talk about it differently maybe in the hospital setting than what we talk about it on the outpatient side. And of course, I spend most of my time in the hospital. And so what we often see in the hospital side is kind of the consequences of maybe how antibiotics were used on the outpatient side and lead up then to those things that you hear about all the time, like MRSA. You know, MRSA is probably the one that folks have heard about for a long time and causes folks to have a lot of concern, and that's methicillin-resistant Staph aureus. And you've undoubtedly heard about it. It gets a lot of attention. People call it MRSA, and MRSA is really kind of the consequence of antibiotic usage over time. Staph, of course, Staph aureus, we got a big long name for it. You know, of course, that's what we do. We give things big long names. But the staph lives on everybody's skin. I mean, it lives everywhere. But once in a while, somebody will cut their skin and get an infection or something that kind of takes off because something penetrated the skin and they get a staph infection. Well, a staph infection can be fairly minor with just what we call methicillin susceptible, so very susceptible bacteria to normal antibiotics and not be too big of a deal, and most of the time be able to take care of that just on the outpatient side with some simple antibiotics and those types of things. But occasionally, and especially what we've seen more and more of, is this idea of MRSA. And so that particular strain of staph is actually resistant to most of the antibiotics that we would use on the outpatient side and can make you equally sick, but often then land you in the hospital. And of course, then on the hospital side, that's where we get into things like having to isolate patients from each other, having to put on special gowns, those types of things to make sure as you go into the rooms that you don't spread it from one patient to the next to the next. So the hospital setting's different than the outpatient world, but we often deal with, like I said, kind of the consequences. And I know other folks are going to talk a little bit about the conservation of antibiotics on the outpatient side. hugely critical so that when you end up in the hospital for whatever reason, that those routine antibiotics will be successful in being able to treat more serious things like skin infections or pneumonias, those types of things. And right now, when you look kind of around the region, about 30-35% of our staff are resistant. And that's a lot. That's a big change from where we were 10 and 15 years ago. So it's not a minor problem. And of course, staff's just one example. Lots of different bacteria. Bacteria are really smart. You wouldn't think they'd be so smart, but the reality is they've been around a lot longer than we have, so they must do something right. So bacteria are incredibly smart, so they're incredibly good at surviving and changing their genetic makeup so that when we come up with something to maybe treat it, they mutate and then it doesn't work anymore. And then we have to get smart and go back to the drawing board again to come up with a different treatment. And so staph is probably the one you hear the most about, but you will see folks in the hospital oftentimes, mostly because of the fact there's no pill. There's nothing oral left that they can really take. They're to the point that the bug is so resistant that they have to have an IV. So an interesting kind of a byproduct, I guess, for the hospitals to kind of deal with. And thankfully, we've been able to be ahead of that game with our development of antibiotics and those types of things, but that gets harder and harder if we're not judicious in how we use it. And of course, coming off of COVID, we all just learned a whole lot about the role of antibiotics or the lack thereof in treating viruses. And oftentimes that's where we see the most inappropriate use is somebody receiving an antibiotic because of a viral illness, and then that sets us up for those problems in the hospital.
And to kind of back up a little bit, what is an antibiotic? How does it work?
So there's a lot of different ones, and they all work a little bit differently. Partly because again, those bacteria are so smart that we come up with a way that kind of comes at it from this direction, and the bacteria mutates and changes so it won't come from this direction. So now we got to come up with one that comes from this direction. And so fortunately, we have probably 8 or so classes now of antibiotics that all work a little bit differently. So that just because this antibiotic doesn't work, maybe this antibiotic will. So, but staying ahead of that is hard. And like I said, the antibiotics are very, very smart. What makes a bacteria different than a virus is bacteria actually are a living organism. They're alive all by themselves. So they live on surfaces, they grow in water, they do those types of things. A virus has to invade your cell. It has to invade a host cell. So whether that's a human or that's an animal, but a virus has to use your body's machinery to make it work and to make it replicate and to keep it alive. So viruses, that's why the antibiotics don't work in a viral situation. They work for antibiotics because that's a living, not necessarily breathing, but a living organism, and it's able to go after it in a different way than something that has to manage to attack a virus directly by going through your own cells, which makes it hard because we don't want to kill your own cells.
Right.
So it's really a very interesting thing, but that's what leads then, and that's why the concern about using an antibiotic where it's not necessary, then the bacteria just get smart and unnecessarily when perhaps the illness was viral to begin with.
And you were talking about vaccines. I mean, this takes a lot of work to come up with vaccines to deal with these viruses as well, because they're tricky in their own right, correct?
Absolutely, they're no fools either. So, we have some vaccines that work for viruses, some that work for different types of bacteria. Vaccines work well because they then get your own body to try to get rid of it. So they get your own body revved up to work against either a virus or a bacteria, so that hopefully it stops it in its tracks and uses the best possible mechanism, and that's your own body's immune system. So vaccines are incredibly powerful tools. Both for bacterial and viral infections, but some of them just aren't there yet. As we talked again, the COVID crisis, obviously lots of work going on to develop an effective vaccine. Undoubtedly we'll get somewhere with it, but they take time. MRSA has been around a long time, and although there's some trials of some vaccines, not anything that's really taken the forefront. Other diseases like polio and smallpox and those types of things have been wildly successful by using vaccines and basically eradicated them. So they certainly play a role, and they definitely help to play a role in reducing how much antibiotics people have to take, because if I can give you a vaccine that prevents you from getting pneumonia, then you don't end up in the hospital, and that you don't end up having to have antibiotics like that then potentially exposes that bacteria to it. The bacteria gets smart. Next thing you know, you've got an antibiotic that doesn't work anymore.
That vicious cycle.
Absolutely. Absolutely.
And so as we're taping this in June, and we're hearing a lot of talk about antibodies. What are antibodies?
So that's the body's response to an invader, basically, whether that's a bacterial infection or a viral infection. When the body sees something that doesn't belong there, it mounts an immune response. And the way that works is it creates these things called antibodies. It recognizes the surface of that bacteria and makes these little antibodies that stick to it, so that then they get sucked into the immune system through the spleen and the lymph nodes and all those types of things. So it kind of makes the bacteria sticky, or the virus sticky, for your immune system, so that it gets caught up and then removed by the white blood cells and all those things that you think about, that we all learned about in health class many, many years ago and have forgotten about. Yeah. So for some of us, it's more front of mind than others, no doubt, but allows the body then to filter it out. And what's really cool about most of the antibodies is they have a memory. The body has a memory. So once you've been exposed to something, that's that idea of immunity. So if you are exposed again, the body's response is very, very quick, and it'll come in and very quickly take control over that potential for infection from either the virus or the bacteria that it's susceptible to. So when people start talking about, well, is this vaccine going to create immunity? There's a little bit of a difference between immunity and protection from disease. There's several scenarios, and we see it with the flu shot. Some years it's really, really incredibly effective. Other years maybe not quite so much. And that's all about whether or not those antibodies match up perfectly with that strain that year. And if they don't match up just right, you might get sick, but probably not as sick. And so you get a partial immune response. So, but the antibodies are kind of the sticky stuff that helps the body to filter infectious agents out.
And with the flu shot, is that kind of an educated guess onto which strain will be prevalent that year? Or?
Well, it used to be, and this is my pure speculation, although I think it's based in more science than not. It used to be that things started in the East, so China and that area notoriously is aside from COVID, but long before that area, flu strains for the year tend to originate there, and you could just watch it move around the globe. You just see it gradually move around the globe, and so you had some time from when maybe something emerged before it makes it halfway around the world and is in the U.S. Well, then along came airplanes, and then along came a whole bunch of huge amounts of air travel, like what we see now. So it's harder to have that lead-in time so that you're able to get that vaccine exactly the way you want it. So yes, it's a guess, but it's an educated guess, because you know what's going on over there. But the interval that we used to have has gotten much shorter. And when everybody had to look at all the maps of COVID a million times, well, they dropped in with airplanes. It dropped into Seattle, dropped into California, Chicago, New York, came over on a plane, and then spread out like a water droplet from there. And so the flu does the same thing, and our world of very fast travel and international travel makes the art of staying ahead of it even harder.
I bet. I would not want to be in their shoes. And so if we dial back to antibiotics, how often is it that somebody might have an allergic reaction to a certain type of antibiotic?
Sure. Well, sometimes that's even hard to sort out. I mean, there are folks that have a true reaction, kind of like what you think about with bee stings, where somebody really swells up, has trouble breathing, the whole 9 yards, where they have a really severe reaction. Those are extremely rare to most of our antibiotics. I mean, they're 1 in thousands, but there are lots of kind of minor reactions that come along, and somebody just gets a little skin rash or something. Nothing severe that puts their life in danger by any means, but it's still probably a medicine they need to be aware of and kind of stay away from. Probably one of the most confounding variables, though, is just a lot of viruses, as an example, will cause a skin rash. You'll get a skin rash from a virus, and so you go to your doctor and say, hey, I've got whatever respiratory illness, and especially in children, you see it all the the time, and they get started on an antibiotic because they're concerned about it being a bacteria, and then 3 or 4 days later they get a rash, and everybody goes, oh, they're allergic to penicillin or amoxicillin, or whichever one. In reality, it was probably just the virus itself caused the rash. Right now there's a lot of questions in the hospital setting, especially about doing some additional testing to patients that have identified an allergy, especially to drugs like penicillin, because those drugs could still be very useful, and sometimes our choices are so few because of the resistant pattern of the bacteria that we'd like to be able to go ahead and use a penicillin type medicine. And somebody says, well, back in 1945 I had a rash and I've considered myself allergic ever since.
Yeah.
You're going, man, you took out a whole class of medicine. It sure would be nice. And so several folks now have developed a variety of protocols to try to really test somebody to see if they're truly allergic. And then there's also some strategies even to desensitize somebody that's allergic to penicillins and things like that, kind of like allergy shots, like back when folks get allergy shots for pollen and stuff like that. I mean, they work by kind of giving you a small amount and then gradually increasing that amount over time so the body starts to ignore it. Same idea with desensitizing people to drugs like penicillin. So, but that's all part of this idea of trying to use the most effective but the narrowest spectrum of antibiotics, so you're not bringing out a shotgun to take care of something that could be done with a BB. Just focusing on very small spectrum antibiotics, and of course costs, and using the least expensive antibiotic, and those types of things all factor in as well. But fortunately, most allergies are more the mild type than the severe reactions, but they can be life-threatening when they're the real ones.
If they don't get taken care of quickly, can they develop into something more severe, especially with like a severe rash? Or
they can, obviously you can get some rashes, even get so bad that you get skin breakdown. You worry about, infections and things like that, and sometimes they even cause peeling of the skin, which can be dangerous. Wow. The ones you worry about, though, are the ones that people get trouble. They get swelling in their throat, their tongue, they start having problems breathing, and those are life-threatening. That's a 911 scenario where, you need to be calling 911 and being taken to an emergency room.
And so the way that you were describing it, if somebody maybe has a mild rash and it could help something bigger, you'll help them treat the rash, but they need that antibiotic. They might, yeah. Okay.
That might be their only choice. And so we, work around kind of the mild reaction by using some other medicines, some antihistamines, those types of things to kind of keep things in check if that's the only choice. Now, knock on wood, most of the time we still have another option for an antibiotic because, again, we've got several classes, but there's certainly situations where because of these resistant bugs, that's getting harder to do. So we all need to be thoughtful about every time we use an antibiotic.
And let's talk about dosage, because I've always heard if you start a dose, you're supposed to finish it all the way through. True or false?
That's true. That's
okay.
True. Now there is a lot of question now about how long's the right amount. There are certain diseases where we've actually studied it pretty thoroughly and say, you need to take this for 10 days, and we know that as fact. For lots of different things, or some bloodstream infections, even 6 weeks and things like that, very extended amounts of treatment. But that's been studied and proven. There's an awful lot of things, maybe some ears and stuff like that, where there's some studies that just maybe even a single dose might be enough, just to get rid of the pain, and that's all you really need to clear up something that's a minor infection. And so trying to use as little antibiotic, one of the things you want to do is use the shortest duration you possibly can. But on the other side of the equation, if you don't treat someone long enough and they only partially treat an infection, so if you've got an abscess, a pocket of pus in there, and you drain that, but then you put them on antibiotic, if they don't get that totally killed, that bacteria that's still staying behind in there might be resistant now to the antibiotic you were using. So so you need to follow what the doc says.
Yeah.
And sometimes the doc stuff is based in some really good science. Sometimes it's just a best guess. But
well, I feel like most commonly I hear of folks when they start to feel better.
Yeah.
They stop it. So the detriment to that is
now
resistance.
You've potentially resistance. Exactly. You've potentially shown the bacteria your gun. Here's my weapon that I'm going to use against you, and then at the same time, then not gotten rid of all the bacteria. So some of them now know how to get around it. So yeah, you kind of did yourself no favor by shortening the duration of treatment in that situation.
And I feel like a lot of people, after they do that, they say it comes back
twice
as worse, twice as bad.
And then they have to change antibiotics 2 or 3 times to finally get rid of something. And again, that's that idea of emerging resistance that is why you want to make sure if you're going to take it, you take it the way they tell you to.
And so if there are other skin conditions or infections, can you talk about some of those maybe similar to MRSA? I think C. diff? I have a nurse as a sister-in-law, and she tells me that everyone at the hospital is wary of that.
Absolutely, and rightly so. That's not a skin thing. That's actually an infection that happens. Bacteria, like I said, are smart, but your body's full of tons of bacteria. And of course, the intestinal tract and the colon especially is just chock full of bacteria. That's how your food gets broken down. That's how the colon is supposed to work. So there's tons of bacteria in there. Well, when we pick an antibiotic, especially when you pick a big one, it's not necessarily selective that it only kills the bad bacteria. It might kill the good bacteria. So that bacteria that you have in your colon that's supposed to be there gets killed by the use of the antibiotic. And then some bad bugs that are in there, like C. diff, which there's a lot of folks that have C. diff just as part of their normal intestinal tract, then takes off and takes over. And it unfortunately can become a very life-threatening illness. I mean, it causes diarrhea in its kind of its mild form, but when it becomes severe, it can actually cause the intestine to die, make people incredibly ill, and even be fatal. And so, again, this idea of using as narrow of an antibiotic as you possibly can to hopefully prevent killing excess bacteria. So you try to keep as much healthy bacteria as you can alive, using the shortest duration you possibly can. So again, you don't end up killing more there than you intended to. And it's also a role where, and it's still a little bit debated, but nobody's been able to say that it's necessarily a bad thing, and that's probiotics.
I was just going to ask, is that fluff or is it actually helpful?
We think it's probably helpful.
Okay.
I mean, they've studied it and restudied it. What they haven't been able to show is that it does anything terrible. And it makes sense that it would be beneficial. If you're putting back the good bacteria, that makes sense that it should be helpful. So, but it has gone back and forth. I mean, in the however many years I've been playing this game, we've said, oh my gosh, everybody needs to be on them. Everybody needs to be on them even when they're not on antibiotics, all the way to, don't bother, to somewhere in between. And I think we're probably somewhere in between. But not a bad thing, for sure.
Other than putting the good bacteria in, are there other benefits to the body of a probiotic?
It's debated. Certainly there's some thoughts in folks that have intestinal problems, especially in general, with like irritable bowel and that type of stuff, that there's something messed up in what we call the flora of the intestine, meaning the bacteria that live in the intestine. And by putting back in some healthy bacteria, it straightens things out and improves them. Lots of debate, though. I mean, they really are subject to debate, but again, seem to be very harmless, and certainly for folks that get the benefit, it's a huge benefit for them. So I can't argue with that. So.
And so when you're on a very strong antibiotic, sometimes that has the tendency to upset your tummy. Is there ways to kind of combat that? Because you're already not feeling well and taking the antibiotic, but you don't want to feel even worse.
Yeah, most of our antibiotics it's fair game to eat with, and oddly enough, even though nausea is a side effect for some of them, normally if folks can eat with them, that helps. So making sure that you do put a little something in your stomach, even if it's just bread or something like that. Most of the newer antibiotics have the ability to have something in the stomach and it not cause any problem with the effectiveness of the antibiotic. Usually, and certainly routinely anymore, if it's an antibiotic you have to take on an empty stomach, it will say, take this on an empty stomach. So without that, then I would definitely make sure to eat a little bit of something. And of course, just doing those things that are so hard to do when you're sick, like trying to keep yourself well hydrated, trying to kind of ward off nausea in general will help it so that when you do take that medicine, it doesn't bother you quite as much. But I've been there and done that, where you don't even feel like much of anything, much less.
You just kind of look at the food at the table and you say, oh, no, I can't.
Yeah, no, thank you, no.
But sports drinks can be a great way to help rehydrate rehydrate folks.
Absolutely. I mean, they're just a concentration of sugar and electrolytes for the most part, and you know, and Pedialyte in kids is not the same idea, but it's very similar. You know, the rehydration drinks, you can even make them at home. You know, that you can actually create your own oral rehydration solution out there that is published on the websites all over the place. And so, but it's just kind of getting you some salt back, some potassium back, some sugar. You know, just trying to kind of be gentle on your stomach, but at the same time getting back some of those things that you're losing.
And we're in our last minute. Any advice for folks as they go out into the world and combat these viruses and bacteria that are everywhere?
Wash your hands, wash your hands, wash your hands. I don't know if I can say that often enough, but that really is huge. You know, we certainly learned a lot about that most recently with the COVID epidemic and those types of things. And it really is true. You know, my grandmother said it for 50 years, and I think she was right, you know, and, you know, wash your hands before you eat, those types of things when you're putting your hands to your mouth. But then also, you know, trying to be mindful about the use of antibiotics, because on the hospital side, it really does become a big deal. And you know, when we get in situations where we can't help someone because there's simply no treatment, those are incredibly difficult places to be. And so by helping to collaborate with those outpatient docs and being mindful of the cold and flu season and recognizing that many of those things are viruses, hopefully we'll use less antibiotic so that when you need them, they're there for you.
Gotta have them there.
Yep.
All right, good stuff. Thank you so much, Dr. Jennings, for being here with us. And you heard it here, folks. Wash your hands. We'll see you next time.
Carl is redefining healthcare around you, innovating new solutions and offering all levels of care when and where you need it. Investing in technology and research to optimize healthcare, Carl, with Health Alliance, is always at the forefront to help you thrive.
They're the ones who raise the bar. The ones dedicated to providing care in the most demanding of circumstances. The ones that understand the healing benefits of kindness and compassion. They're the people of Sarah Bush Lincoln, and they set the bar high. Sarah Bush Lincoln, trusted, compassionate care right here close to home.
For over 50 years, Horizon Health has been keeping you and your family healthy. And although some things have changed, Horizon Health's commitment to meet the ever-changing needs of our community has remained the same. Horizon Health, 50 years strong.